All right. Good morning, good afternoon, good evening, depending on where you are around the globe. I would like to welcome you to the 12th Annual Health and Humanitarian Logistics Conference. In case you are joining us now, if you are continuing with us from the morning, thank you for your continuing participation. So it's my honor and pleasure to introduce three wonderful speakers at our first panel discussion of the conference. They each have such vast experiences and accomplishments. I have to keep these introductions short just to make sure we have enough time to give them, to share their insights. So our first speaker is Samira Asma. She is the Assistant Director for Data Analytics and Delivery for Impact at the World Health Organization. She leads efforts to use timely, reliable, and actionable data to drive progress towards the Sustainable Development Goals and also the triple billion targets with the goal of achieving increased universal health coverage, protection from health emergencies, and improved health and well-being. She has extensive experiences in public health programs and policies and is an outstanding researcher with numerous impactful publications in addition to her impact in practice. Jenny Parker is the Vice President of Infectious Disease Programs at Cdc Foundation. With her extensive global health management and operations experience, she provides leadership and support for the domestic and global infectious disease programs at the CDC Foundation, and also oversees overall program effectiveness. Prior to joining the CDC Foundation, she worked for 25 years at the Centers for Disease Control and Prevention, CDC, in a variety of roles, including her service as the Deputy Director for Management and Overseas Operations in CDC's Center for Global Health, overseeing a multi-billion-dollar budget supporting 2,800 staff in over 60 countries. And in 2016, she received the federal government's prestigious Presidential Rank Award for her meritorious service during the West Africa Ebola Outbreak. Our third speaker today is Suvi Rautio. She is the Deputy Director of Supply Chain in Unicef's Supply Division. She oversees a variety of supply chain functions and operations and also focuses on strengthening government supply chain systems. Previously, she served as Chief of Supply and Procurement in Unicef India, as Unicef Eastern and Southern Africa Regional Chief of Supply, and also Chief of Procurement Services and Team Leader of HIV/AIDS. Her prior work experiences span many other countries and regions around the world, including Benin, Fiji, Hong Kong, Taiwan, and I believe also Turkey. And joining me in moderating this wonderful panel is my colleague Prashanth Yoda. Many of you probably know Prashanth. He's a senior fellow at the Center for Global Development. He's an affiliate professor at INSEAD and also a lecturer at Harvard Medical School. Prashanth is a globally recognized scholar in the area of healthcare supply chains with numerous scientific publications, and he also has a very prominent presence in media. Prior to his current positions, he worked at the Bill and Melinda Gates Foundation and as an advisor to various global health agencies. And he also serves on the boards of social enterprises and nonprofits working on healthcare supply chains. So with that, please join me in welcoming our wonderful panel. I'm going to turn it over to them now. And I believe I'm going to stop sharing my screen so that I can turn it over to Suvi, who is going to go first. So each of our panelists are going to give remarks for about 8 to 10 minutes, and then we will have an open discussion. So for our attendees, you can write comments in the chat, I believe, or the Q&A button at the bottom, but we will get to all the questions after we give a chance to all of our panelists to share some initial remarks. With that, I'm going to turn it over to Suvi.
Thank you very much. Now let me see if I can share my screen. So I will be talking about UNICEF's work to assist the government to strengthen their supply chains. And this is related to COVID. It's also related to other emergencies and to the regular program activities. Next one, please. So the analysis shows that barriers in the area of supply chain, so this is a major factor to hampering the end users to have access to health supplies. Now this data here on the left-hand side, so this is data annually collected by WHO, that shows that 45% of lower and upper middle income countries, so they suffer from stockouts of vaccines during 2019. And so this of course then led to interruptions in the immunization related supply services. And the data also shows that in fact, 26% in 2019, the governments did actually not know the cause for the stockouts and interruption of the supply chains in the area of immunization. Now these figures here on the right hand side, so they show that in fact the situation has not gotten better during the last decade. In fact, it has gotten worse. And this, of course, might be for the reason that the data collection and the analysis is better now than it used to be. But the main message is that indeed the non-functioning of the supply chain is a major barrier to health programs. Next one, please. Right, so Unicef has a health systems strengthening approach that focuses on several areas of the health systems. Quality of care, data and digital health, governance and partnerships, district health systems, and financing areas. And a very important part of the Unicef approach to health system strengthening is the supply chain management. And the supply chain management is of course related to many of the other pillars in the health system strengthening. Just to mention one, the health workforce, because without having adequate health workforce in numbers and well-trained and competent to work in the area of supply chain management, we will not have a well-functioning supply chain system. So these rainbow-colored boxes here on the upper part of the slide, so that describes the supply chain. So from definition of needs and budgeting all the way to monitoring and evaluation of the supply chain. And so when we work in the area of supply chain, so in Unicef, so we analyze all of these different parts of the supply chain, because if any of the supply chain parts is not working, the entire supply chain is not working optimally. And these areas below, so people and practices, data analytics, system design, financing and policy and regulatory frameworks. So we use these, what we call enablers, in the various areas of the supply chain to analyze the functioning of the supply chain and to identify gaps. Next one, please. So Together with our partners, we have developed a model which we call maturity matrix. And the maturity matrix is here in the middle. So it's a relatively simple tool to use. And the exercise when we work with this model, so the exercise is led by governments and helped or assisted by Unicef and by the other partners. So we analyze each part of the supply chain as well as the enablers. And then we rate the functioning of these different parts of the chain from 1 to 5. So 1 being what does not function well, and 5 that really functions optimally. And in a very collaborative environment. So we analyze these different parts and identify the gaps and what parts of the supply chain are not functioning. So this model can be used to analyze the entire, let's say, health supply chain, or to specifically target an area of the supply chain where there are issues. And there are a couple of examples here that talk about nutrition supply chain. And just to share a few words about Central African Republic, where we did this exercise, as it was evident that the nutrition supplies did not reach the end users. In some extent, they did not reach the facilities, and even less so the end users. And so through using this model, we identified the gaps and designed and implement an improvement project and implemented it together with the government and the partners. And this led then to a huge improvement in the increase of availability of these nutrition supplies where they should end up in the to be available to the end users. Then another nice point about this model is because it's a relatively easy model, so it's used for monitoring and analysis of how the supply chains are improving over time. So like in this Central African Republic case, so we did another analysis after about 8 months to indeed notice and to analyze if the supply chains had improved, which they had in this case. So it was a successful undertaking. Next one, please. Right. So Malawi was the first country that opened testing of drones for the use of health supply systems. And they first used the drones to survey areas of Malawi that had been heavily affected by floods. And this was to identify the conditions of the infrastructure and the roads to the facilities, and to see indeed if these emergency supplies could be transferred all the way to the facilities, or whether the roads had been destroyed, and then to see indeed what are the alternative ways of delivery. Now, then Malawi moved on, and they used drones to collect blood samples for HIV/AIDS that needed to be very rapidly lifted for analysis. And at the same time, in 2017, Vanuatu actually used drones for delivering vaccines to some of the hard-to-reach islands. Now, this year, in January, so Unicef, together with the government of Malawi, with the partners, established an African drone and data academy to study the whole area of how the drones could be better used to equip the young people in Malawi and in the other African countries with the knowledge of using drones, and then to discuss this, how to solve these common bottlenecks, such as regulatory issues for using drones. Next one. Now, the last example I wanted to give is South Sudan. Now, South Sudan suffers yearly severe floods, and the infrastructure leaves a lot of room for improvement. And when the rains start, so all the supplies need to be airlifted by small aircrafts or by helicopters, because the roads are totally destroyed. And so, again, doing this analysis, led by the government, assisted by Unicef and other partners, so we were able to set up a system that all supplies were pre-positioned in the various areas of South Sudan before the rains started. And this, of course, led to huge savings. Approximately, the estimate was cost avoidance of $5 million per year, as well as, of course, decrease in the reduction of the CO2 emissions. Now, very rapidly in the UNICEF internet site, so we have plenty of examples of supply chain strengthening, and we have many more models that are presented there, as well as a number of tools. So I hope that you will have a chance to log into the UNICEF internet site and to get a little bit more familiar with the work that we are doing in this area. So thank you very much.
Thank you so much for having WHO be represented on the panel, an important and a very timely topic. Today, we have reached, as you all know, 1 million deaths in 10 months. Many of those were preventable. So it's an important, tragic milestone. And the topic that you're discussing today is also going to be extremely important. What I would like to discuss today with you is the importance of data and the strengthening of not only health systems but health information systems, so that the supply chains are uninterrupted. While we have a gloomy picture today, there has also been some optimistic news. As you know, that world is nearly polio free, and we announced that the African region was designated polio free just a few weeks ago. The underlying reason of this was political commitment, good data systems, good primary healthcare workforce, the whole approach of primary healthcare. But most importantly, the supply chain was very important for us to move towards this stage. We never had imagined that the world will soon be rid of polio virus. And I think we can take more hope from this, and hopefully we will be saying the same for COVID-19. It is possible. Dr. Tedros says the best defense against any outbreak is a very strong health systems. Since COVID, we did the survey of essential health services, and the disruption that COVID-19 has caused, and the fact that real-time monitoring is so important for us. And the survey showed that 90% of countries reported disruption in essential services, and 50% of a set of 25 crucial health service tracers were impacted. Routine immunizations to NCD diagnostics and treatment, family planning and contraception, facility-based services, mental health services, importantly, emergency services, basic things as blood transfusion, emergency services. These all have been interrupted and impacted. So there are lessons to be learned from this. But the gains that we had made to achieve the SDGs, we have already been sliding back in a number of indicators. There are 57 of the health-related SDGs, but I will go to the next one. Yes. So there are about 57 health-related SDGs, and health really binds all the SDGs together, whether it is poverty to equalities to innovations, etc. But what we are seeing is that there are significant data gaps. Over 50 more than half of the countries of the world are unable to report on even less than half of the health-related SDGs. So there is a fundamental issue here. For supplies, we need good data systems as well. So this is the state today, and WHO has gone through its over 70 years of its history, a very sweeping transformation, and under the leadership of Dr. Tedros has become a very data-driven and a results-based organization. It is underpinned by $3 billion targets. For each of the billions, it is 1 billion more people enjoying better health, 1 billion more people benefiting from universal health coverage, and 1 billion more people better protected, now the whole world to be better protected from health emergencies. This has been a vision which is underpinned by results and a data-driven mechanism, and the indicators underlying all of these 3 billions measured by each of the respective indices, there are a lot of areas which cross-cuts with the supply chain. Whether we look at the healthier population and public policy, there are supply chain issues. Whether we look at emergencies or whether we look at universal health coverage and access to essential services, diagnostics, etc. So there is a lot that underpins this. And the goal was to reach this by 2023, which is a midpoint to 2030, when the SDG started in 2015. But the point is that with COVID, I think there is a sense of urgency to keep up with the gains that we have made and not to lose and derail those further, but as well as to meet the SDGs, and we knew that world was already not on track. So data systems become extremely important. If we don't know whether with confidence if we are making progress or not, it would be hard. So my message here is that for the topic, such an important topic around logistics and supply, data and the links becomes so critical and so very important. About a month ago, WHO, along with partner organizations, launched a Score for Health data technical package. It is for the first time about 90 evidence-based technical resources have been compiled together that go from surveys to counting births and deaths and causes of deaths and optimizing health service data, reviewing progress and performance and data sharing, and finally to use the data to drive policy and performance. Again, you will see a very intricate connection across all of this with the supply chain and the mechanisms to gather information. So Score for Health data technical package is being reviewed by each of the country, and we know now in next 2 months how countries have self-assessed where they are with the scoring of each of these 5 pillars. That will bring to us in a very targeted way where we can address the data gaps. If a country, for example, is got gaps, especially with birth and death certification and cause of death information, that is where the investments would go. So this is a resource that I wanted to bring to everyone, and stay tuned for the next announcement as to how each of the countries are assessed, as well as the global picture across all of these. This is available on WHO website. And finally, I would like to just say about the ACT Accelerator. Yesterday was the launch of the 120 million doses of rapid COVID diagnostic tests will be made available. So how does the world and countries and communities grapple with the supply also when the vaccines become available? If I take you back to the triple billion construct, the health emergencies index in particular focuses on preparedness, which is with the international health regulations. And we recognize that many of the countries that had reported to be very well prepared have also faced a big brunt from COVID deaths. The second component of that health emergencies index is about time to respond once an epidemic strikes. What does it take? And we have seen again that countries like South Korea or Vietnam and Singapore and many others were able to stop it on track or to recover like Italy and others have done. The third component is prevention in there, which brings back to when the vaccine becomes available and how do we put in place the entire supply system. And the WHO has been doing a lot of work with the logistics in partnership with Unicef and many other UN agencies and the ministries of health and partners and donors and academic institutions in terms of providing the logistics of PPE and diagnostics. And now I think the world is getting prepared under the ACT Accelerator for the distribution of the vaccines when that becomes available. As you see, one of the work stream in the ACT Accelerator is the supply chain. But all of this is going to depend on a very robust primary healthcare systems. And WHO has prioritized primary healthcare, and Dr. Tedros says that there is no universal health care without primary health care. And the various pillars of the primary health care system, which was the promise of Alma-Ata several years ago, I think we are revisiting and re-energizing that. So I want to link the whole discussion around logistics and supply and to the elements of the primary healthcare system, because that is where I think we will succeed or we fail. We better not fail. So look forward to more dialogue, and I'm very heartened that Georgia Tech is hosting this. Atlanta has been my home for more than 20 years, coming from CDC. And I've worked very closely with Prashanth on the cardiovascular disease and the distribution of medicines as simple as for hypertension, and the whole supply of something as simple as management of high blood pressure, and we are failing because of lack of very coherent supply chain. We know what works, we know what medicines, we have the protocols, access to medicines, they are cheap. It may cost less than $5 per person per year, but supply chain fails us and blood pressure becomes the leading cause of preventable deaths and also leading cause of cardiovascular heart attacks and stroke. So again, to draw that connection and my work with Prashanth. So thank you very much. Look forward to further discussions.
Okay. I'm really pleased to be here this afternoon, and I'm going to be talking about a little bit different aspect with more focus on the health system strengthening piece, which I think goes hand in hand with the logistics health, really making sure that our logistics are set up to get commodities out. I work with the Cdc Foundation, and the Cdc Foundation is actually a nonprofit that exists. It was established by the U.S. Congress to support mobilizing philanthropy and private partnerships in support of CDC's work. So it's really a fascinating partnership between government and non-government. As most of you know, CDC is really working to fight outbreaks, reduce healthcare spending, providing guidelines and health data. And, I think everybody knows the challenges that we're facing today with COVID. It's really because we need effective public health everywhere around the world. So I want to talk a little bit about global health security, which really was established to address the need to build healthcare systems capacity to, number one, try to prevent avoidable outbreaks. And you can do that by immunization, really antimicrobial resistance. But if you can't prevent it, then let's try to detect it really quickly so that then we can respond to it. And so I'm going to talk a little bit about combining some of the work that CDC does, as well as the CDC Foundation, focusing on public-private partnerships, and also talking a little bit about kind of my perception of what some of the challenges are in building cross-cutting health systems capacity. Oftentimes, funding is provided categorically. For example, one of the largest global health programs in the United States is the President's Emergency Plan for AIDS Relief. And I think PEPFAR really in the very beginning tried to also support system strengthening at the same time that they were also addressing the disease. And we'll talk a little bit more about that. Global health security has really been focused on just the capacity building piece. So CDC's role in global health security is really to focus on building up lab capacity, surveillance capacity, having an emergency operations centers process to manage whatever outbreak is happening or even monitor ongoing disease, and then workforce development. And these are all difficult systems capacity building time. And so we're going to talk a little bit about how does this happen. CDC does have a very large presence overseas, and they really have been working with the ministries of health to build up sustainable health systems. And it really has to be within the country context. They have over 1,700 staff working in 63 countries, and they also have a lot of staff working in international organizations. For example, working there with Samira at the World Health Organization. I want to use this example to share a concrete example of what I mean by long-term health systems capacity building and what that takes. When Ebola broke out in 2014 and 2015, CDC had not been in Liberia, Sierra Leone, or Guinea with the exception of there was one malaria resident advisor in one of the 3 countries, but CDC had never had a presence there, never worked there. In contrast, in Nigeria, the CDC had started working there around in 2000 with the HIV/AIDS program, and later expansions with PEPFAR, the President's Emergency Plan for AIDS Relief. They had used HIV funding to support the field epidemiology training program to build up the capacity of people to be able to respond to outbreaks. And that had been going on for many years before the Ebola outbreak started. In Nigeria, there was also public-private partnership work to address polio in Nigeria. And as Samira has mentioned, we're very close to eliminating polio. And there was a lot of polio in Nigeria, and the Gates Foundation, in addition to working with CDC, really strengthened. They had an emergency operations center just focused on polio. They had a lot of contact tracers that had been trained to address polio. So when Ebola hit Nigeria, I've heard Tom Frieden, who was the CDC director at the time, say this many times, but that he was more afraid than ever before that Ebola would become like HIV/AIDS and spread around the world, because Nigeria is a very, very huge place. And so what happened in Nigeria is Dr. Frieden reached out to leadership within Nigeria, and they were able to pull together many of the people that had been trained in field epidemiology training program. They converted the emergency operations center to address that had been used for polio and used it for Ebola. And I want you to compare these, I want you to compare the differences in the response in Liberia and Nigeria. And you can see that, number one, they detected it within 5 days in Nigeria. It took 90 days in Liberia because they didn't even have the capacity to know what they had, what disease they had. In Liberia, they had 10,600 cases. They had 4,800 fatalities. In Nigeria, thankfully for all of us in the world, there were only 19 cases and 7 fatalities. I'm not saying that there has to be a CDC presence. What I'm saying is there has to be long-term emphasis on health systems capacity building in these areas: laboratory, surveillance, emergency operations center, and workforce development. So next I want to talk a little bit more about public-private partnerships. I really believe that the focus of your conference is on agility and flexibility. And I think that's really needed by having both government and the private sector working together. So I want to provide an example of what happened in Ebola. The Ebola outbreak, as everyone knows, was about as scary. I mean, COVID is scary too, but I think the Ebola outbreak, if you think about it, we had very few cases in the United States. But all over the world, I think some of the countries who were well prepared for COVID is because they had either MERS or they had Ebola, and they learned from that. But what happened in Ebola is that we had a very strong support from the private sector through the CDC Foundation. And some examples of how that partnership played out was the Paul Allen Foundation provided funding to build 3 emergency operations centers, one for Liberia, one for Guinea, and one for Sierra Leone. And this facility served as the site for the response. In addition, funds provided through the foundation, working closely with CDC, hand in hand with CDC on the ground, they trained people in the field epidemiology training program. And trained massive numbers of people to be able to go out and do contact tracing. And this continues. CDC has been able to continue working in those 3 countries and have continued to work to build the health system's capacity in those 4 areas. I think what oftentimes we don't want to invest in health systems capacity. It's not sexy, but I think what's really important for us to know is we have to have continuous investment. It has to be collective and it has to be worldwide to really make a difference. We want to prevent this. This is a photo of a cemetery for Ebola patients who died. And that's our CDC Foundation CEO and President, Judy Monroe, who went out to visit the countries to try to assure that some of the funding that was put into those countries through both CDC and through the foundation was able to build sustainable capacity. So I'm going to end with a COVID slide. The CDC Foundation has raised more money than ever from the private sector philanthropy corporations for COVID. And this funding has been able to support medical supplies, PPE, deploying emergency staffing, communications, focusing, really trying to target vulnerable communities, boosting clinical research, and building global capacity and response. And so what I would really like to emphasize is the importance of public-private partnerships where we all work together to try to build the worldwide health systems capacity, public health capacity to deal with outbreaks. Because together, our impact is greater. Thank you.
Before getting into questions and responses, firstly, I want to remind all our attendees that questions for our panel, please post them on the chat. Secondly, I want to start by thanking Suvi, Samira, and Jenny. I know what your days look like, and I know everything that's happening at WHO HQ, at Unicef Supply Division, at CDC, and partners of CDC, like the Cdc Foundation. So it means a lot for you to have taken out time and come share your insights with us. I think a lot of people who are not as deeply embedded in the structures that have helped with COVID response supplies, so whether it's the ACT Accelerator, the Supply Division's work, I think one key question in their mind is, how well are we coordinating? Are we this time working together better, right? This has been a common question, a common critique that multiple agencies don't always come together in the right manner. So anything that you can share, and this is a question both to Samira and to Suvi, about how we've tried to do this better this time, and what is a way we are thinking about doing it even better when we face an emergency like this in the future. So any thoughts and insights you can share, and meanwhile, questions from attendees, please keep them coming. So should we start with you, Samira, and then we'll go to Suvi?
Thank you, Prashanth. I think ACT Accelerator is a real testament of multiple agencies coming together to respond to the global crisis and the pandemic. So that has, and the sharing of various areas of expertise, whether it is Gavi or UNICEF or WHO and UNCTAD and many other UN partners, Global Fund, World Bank. So that has been, I think, unparalleled, that we have seen so quickly that all the partners coming together. And same is happening at the regional level of WHOs and the countries. What we could do better, I think, if we can have a very coherent early warning and response systems that are more digital based and technology facilitated. I think that is what the world would benefit from and be better prepared, because there will be a next epidemic, there will be a next pandemic. The question will be that what are the lessons that we have learned so that we are not taken by surprise as we have been. And we also see the countries, as I mentioned earlier, those that had good systems in place were the ones that were able to respond rapidly. so we know what works, but I hope this helps. Thank you.
Suvi, your thoughts on this?
Yes, thank you. So for the initial COVID response, WHO established something which is called the COVID supply chain system that indeed draw in all the UN agencies, but also others such as Global Fund, Unitaid, Find, and there were many others. And so the idea was that there would be a better coordination, better visibility, better service provided to the governments. And part of this was to establish 3 consortia for procurement, and one was for PPEs, and as you know, it was an inherently difficult area to get going at the beginning of the epidemic, with China closing the borders, total global unavailability of PPEs, etc. So this working through this consortia, and Unicef actually took the lead in the procurement of PPEs and putting these long-term arrangements in place with the suppliers. Then we had other consortia for oxygen and for diagnostics, where other partners took the lead. And so indeed the collaboration through this consortia and dividing the work in between the agencies. So this really, brought in a lot of advantages. But this did not only happen now, I mean, on regular basis. So almost all the procurement UNICEF does, and UNICEF procurement value per year is about between $3.5 to $3.8 billion. So almost all the procurement we do is in collaboration with other agencies. And I can give an example on vaccines, which is the largest commodity that we procure. And UNICEF, in fact, procures vaccines to reach 45% of world's children. So all the quality control is done by WHO. And this, of course, will be the same for the COVID vaccine, whereas UNICEF does the procurement part. And so there's a regularly ongoing collaboration within the agencies and also with others.
Thanks, Suvi. And Jenny, any thoughts you have on this? And I have one additional question I wanted to add, which is the head of Africa CDC, John Kingerson, was going to join us. He sends apologies. But I think as compared to previous health emergencies, when there wasn't an institution like the Africa CDC, but now we have the Africa CDC, it's growing, it's stronger. How do you see the role of the bilateral, the US CDC helping countries set up versus now working more closely with Africa CDC? So I know, this is an evolving area, but any thoughts you would like to share on that as well?
I actually will respond a little bit to that. I was working at CDC in the Center for Global Health when Dr. Tom Kenyon was the center director, and he was very involved in helping establish the Africa CDC. He worked very closely, through quite a partnership with the U.S. government and with the African community to do that. I think it's really, really important for it to be the Africa CDC to help coordinate across the countries in Africa. And I think, to Samira's point about having an early response system, I really do think that we as a world need to come together to do that, because we need it within Africa, but we need it much broader than Africa. And I can't say more that to support the data. When Samira is talking about data is really foundational and critical to do early detection, but also to share the information. So I hate that John couldn't be here today. He would have been an amazing speaker. Just so everybody knows, John Nkangazon really led the lab systems building capacity through in PEPFAR, but he did it in a way that he always approached it from a health systems capacity building, where each country would have a national strategy that was not just focused on HIV, but to have a national reference lab and have transportation systems set up to have regional nodes to be able to feed into the national system. So I applaud John, and I hate that he was not able to come today. He would have been an amazing speaker and able to provide a lot more content than I am today. Thank you.
Thanks, Jenny. I'm going to pass to Pinar in a second, but one additional thought I want to leave to our panelists for either responding or any comments you may have later is, I think when we talk about data and data, coming from district levels or, even one level lower, more granular from health facilities, we often think of data coming from systems which are recording systems or what we commonly call as HMIS systems. But often we forget that the supply chain brings very crucial data sets for health systems planning. And the data coming from the supply chain is more real time, it's more granular, oftentimes it has lesser biases, but we don't see a coming together of health data systems which are working largely on the DHIS2 and lower level DHIS models and the supply chain data. And I think there's been some work, but again, I think, area that we all need to probably reflect on more. So with that, over to Pinar for other sets of questions.
Thank you so much. Thank you. This is fantastic. And we have several questions coming in the Q&A. Our panelists, please check those out and you can respond to any of them. But my question is a little bit about human behavior. So we learn and know quite a bit about infectious disease, how it spreads, what we need to do to stop it. We develop testing capacity and so on. But at the end of the day, a lot of what happens also depends on how people behave. And this may vary a lot within a country as well as across countries, or even in smaller areas such as a college campus. So you'll see a variety of behaviors. So can you comment a little bit on, how do we convince people to do the right thing? And it's probably easier said than done, but, are there any strategies that have worked and anything that we can learn and apply moving forward?
So if I may, thank you, Pinar, for that very important question. Again, I think facts, has to be preceding action, and actions precede facts, and then facts are basically driven by data and the information that we articulate. So taking an example of the district health information system, active in a number of countries in Africa, Latin America, and Asia. What we ought to be doing is to strengthening the district health information systems so that they are not used only for reporting upwards, but how the data is used to improve performance and practice. I think that is going to be extremely important. And hopefully the numbers will, and the improvements will drive the change in culture and behavior. Just taking WHO as an entity and an organization, the whole movement over the past 2 years of transformation has been to really bring a cultural shift in the minds of everyone, about 8,000 people who work for WHO across the world, to be very data driven. The time we are spending, are we making an impact? Not just an impact, but a measurable impact. Not just releasing reports, but are we making an impact in the lives of the citizens we serve? So that has been a whole cultural shift. It will take time, but I think effective communication and facts, and also that positive reinforcing that it will work, and our times are limited here. So make the best of it.
Thank you very much. So in the chat, I see quite a few questions that refer to, how can we do better in terms of collaboration and coordination across different agencies. Earlier, we heard from you, our wonderful panelists, about the importance of agility and flexibility, and the importance of more collaboration, not only among different government agencies, UN agencies, or NGOs, but also the private sector working together. So that's one question. Maybe if you could, either of you could comment a little bit more on the collaboration, coordination, and also how do we translate some of the learnings from prior outbreaks or other efforts in other in different parts of the world, and then build on them moving forward. So I'll just keep it very broad and open, and I'll let our panelists to pick and choose depending on in which order and how they would like to respond.
So perhaps if I say a little bit about the collaboration and coordination at the country level. So earlier we've been speaking, or perhaps I was speaking rather about the global coordination, but of course the preparedness activities for emergencies is absolutely a crucial undertaking at the country level. And so now, as we speak, so the countries are forming logistics working groups and to begin to prepare for the COVID vaccine. And as you know, this is an undertaking that the world has never done before, with some quite difficult requirements that we might have, such as ultra cold chain requirement at the country level, which certainly is not there in most countries. So at the moment, together with the partners globally, the partners, there's a lot of work going on to prepare checklists, to prepare advice, guidelines, etc. For countries to prepare their readiness for receiving the COVID vaccines. So that's one thing. Then I could see that there is a number of questions concerning local production and local procurement of supplies for emergencies. And this is absolutely one of the focus of UNICEF as a development aid agency. That whatever how we can assist the private sector to work with us in partnership to gear towards providing these life-saving supplies locally with production taking place locally. And we do have a very good example of that. One of the main nutrition items, ready-to-use foods that is used for treatment of severe acute malnutrition, whereby now about 60% of all the procurement actually is produced and takes place in the countries that are also using these nutrition items. And there was a good question here also of items needed for COVID and for other health emergencies, such as, for example, the PPEs. And equally, they're so very important. We are working together with local industries to see how they can be geared up to indeed begin to produce quality supplies for PPEs and for protection and IPC for COVID and other
emergencies.
Thank you.
Maybe I'll just talk a little bit. One of the questions talked about what is it that we can learn in comparing some of the countries who had learned from Ebola and did much better with COVID. And I really think it would be really interesting to do some case studies on that, and I think it's really important. We have to acknowledge in the U.S. we really have not done well, and why is that? We did have score well on the joint evaluation, external evaluation readiness scale. What are the factors? I think it in some ways really shows the importance of a national plan and national leadership in a country in communications. But it'd be fascinating to me to look at, a country like Burkina Faso, who originally they thought there would be a huge problem with COVID, but they've managed it really well. You've got Vietnam, who has managed it real well. Taiwan has done one of the best, managing their COVID outbreak in the world. What did they do? There have been articles published on what they've done, but what can we learn from, what did some of the countries in Africa learn from Ebola compared to other countries who have not responded as well? And I think we have to be honest about that. I think when you were talking about collaboration in the country, Suvi, I think that's really, really important. And having those country being able to respond to, have ongoing practice responding, and in the importance of having an emergency operations center that operates all the time. Dr. Frieden used to say, take your 5 top diseases and track them all the time so that you have your people in place, you have your processes in place, and even if you don't have an outbreak, you're still using that to track your diseases. And so I think there's a lot that can be learned from that, from a practical standpoint, that would benefit all of us. Thank you.
So we are about 5 minutes away from closing time. We have still lots of very interesting questions from the attendees. What I suggest is the following. I want to go to each of our panelists, and with one preface, want to ask them for essentially their closing comments. The preface I want to put forth is, one is that we are learning that there are countries which had resource limitations, but despite that have run their health systems better. What in their preparedness was in place, and preparedness is a very multidimensional thing, as we know, through looking at the GHS index and other things. And how can we as a collective community highlight those examples better so that we have a practical thing to take to leadership, whether it's in the ministries of finance, health, or other, or heads of states. So that's one. So any reflections you have in how we can do that better. The second thing I wanted to mention was, I think we oftentimes have thought about health systems and healthcare supply chains as things we focus on in low and lower middle income countries or middle income countries. I think COVID-19 has highlighted to us that global health supply chains are truly global. We need to work on health systems in our own backyards, wherever if you live in the United States or Europe or other parts of the world. So I think any reflections on, is that going to change the way we think about health systems? Will we see a larger integration of high-income countries and lower-income countries in the health systems improvement agenda, not only as donors and recipients, but as working together to improve health systems? So with that, I want to pass on to Samira for 1 minute closing remarks on this, and I'll go to Suvi and Jenny.
Never underestimate the power of strong data systems. I think is going to be extremely crucial. And also think of preparing for any emergency as a fire department does. It is the muscle that is made because of the practice that is being done and following certain procedures. And it is integrated in a way. So I think silos will not work, only collaboration, as Dr. Tedros says, it is solidarity. We are one global community.
The countries, in order for them to tackle this pandemics and to run their supply chains. So what is very important is the enabling environment in the country. So where we see great successes is indeed when the country has an enabling and facilitating environment. So meaning the governance systems are in place, the budgetary envelopes are in place for important life-saving health supplies, the workforce to serve the population, to provide health services is adequate and is trained. So I think these are some of the key areas in countries that will be able to tackle this pandemic successfully.
Thanks, Suvi. Jenny?
So I think really the things need to be, the fundamentals need to be managed in a practical way at the country level. It's really important to have strong national leadership and political support. It's also important that you have, I loved what Samira said about practicing, like having the fire department practicing. I think that's really important, that those countries will be more successful if they've got these pieces, the basics in place, and have used them regularly. And then to your question about how countries that with less resources did better, I think that's a really interesting question to delve into more, because we should learn from that. And we should, in some of the countries with more resources, take that to heart. And we are a global, and we need to work together, all of us, and not be focused just on our country. And that's the only way we're going to address any type of global outbreak.
Thank you again. I recognize we are almost at time. If it was an in-person health and humanitarian logistics conference, now would be the time for us to go for a coffee break, chat about our many conversations. But hopefully we can do that through Slack or other means for those of you who are in part of that. Let me pass it to Pinar for any final words of closing. But thank you, everyone. Thank you to the panelists, but also all our attendees with their questions, interest, comments.
Thank you.
Thank you. I would like to thank once again to our panelists for taking the time from their busy schedules. They are doing such important work around the world. So thank you for being with us today. And I'm going to pass it back to Jocelyn for some additional tips about staying engaged. Thanks again. And thank you, Prashanth.
Thank you to our sponsors, the UPS Foundation for being a premier sponsor for the 12th year in a row, and Humanics for sponsoring again. They've been a sponsor for us for the past few years, and their engagement is always so needed and welcomed.